Good morning, afternoon, and good evening to you all. This is another webinar of the series of World Family Doctor Day webinar series. Today's webinar is addressing depression in primary healthcare, lessons from the MDD Minds project. I hope you all know about MDD Minds project, which was piloted in 9 countries and now available for you all to access the modules. And it's just not only about online modules, but there were a lot of other things. You would listen to our speakers today, and you will get to know about the experience and the lessons we learned from the project. So while welcoming you all to this webinar, I especially welcome all our speakers. And without much ado, I would like to start. But before that, let me announce you a few housekeeping rules. Please keep your microphones muted while the webinar is going on. But anyway, we will have some time for questions. So then you can, of course, raise your hand and unmute and talk in the case. And also you can post any questions on the chat function, using the chat function. And I am also happy to tell that we have the interpretations active from English to Spanish. So you can always go to the interpretation function and activate from English to Spanish. So now let's start the first introduction or the welcome speech on behalf of every one of us, on behalf of the MDD Minds project, is from one of our mentors, Professor Christos Lionis from Greece. Christos is the chair of the Working Party on Mental Health, and he's a medical doctor, Professor Emeritus of the University of Crete, and Professor of Primary Care and Public Health at the School of Medicine, University of Limassol, Cyprus, and as I told, he's the chair of the WONCA Working Party on Mental Health. Christos, over to you.
Oh, thank you very much. I very much appreciate Sankha. Excellent introduction of the seminar, of the webinar. I needed it just in having the slides, but you needed it in giving me the chance to be a host, because I have difficulties in raising my slides. Okay. Or if it's not possible, potentially.
No, you are a host now.
Oh, that's wonderful. Hearing, fantastic. You can see, I suppose, my slides are quite a short presentation. I'm very happy and privileged just at the moment chairing a working party with many distinguished people, colleagues across different disciplines, and I'm started usually from our family, extensive family, WONCA, global family doctor. I think that is an important organization representing family physicians across the world, 111 countries. Thousands of family physicians are linked with the WONCA. Many thanks to all our leaders, and a current leader and a president is Professor Karen Flegger from Australia. There are many working parties. There are special interest groups. Please join us visiting the Global Family Doctor website in having a better understanding what about the WONCA world, and also just having an opportunity in seeing the working parties as special interest groups. At the moment, we're having more than 300 people already registered, and you kindly invited in visiting the Global Family Doctor, visiting the WONCA Working Party on Mental Health, and very much appreciate if not registered, just make an application. Immediately you having a response for us. I'm thinking there are many activities, of course, in only few minutes. The only that I can see just some illustrative colored slides. The key issue at the moment in our working party is the integration of mental health into primary care. Still is challenging. You can see that a paper and WHO paper since 2008, still the issue needs a thorough attention, and it is one of our first tasks in promoting this global strategy and seeing integrated mental health into primary care. We're having, of course, a lot of efforts in making a link between a very well-known Astana Declaration of a WHO and this paper, a little bit giving more light what exactly WONCA Working Party on Mental Health needed to focus on, just oriented our strategy, our activities, trying in tailoring the needs of a population, mental health care needs, to the Astana Declaration. I think that's both integration of mental health into primary care and Astana Declaration, the principles and the illustrative guidance provided already across world is very important. But coming back, that is the key issue of the today webinar. We're very proud for having such many thanks to many leaders and many stakeholders involved there, but also particularly thanks to my friend and immediately past Professor Chris Dowrick. I think that is another important, challenging project we have. Among our focus and priorities is giving power to the voice of young people, just preparing the future leaders to undertaking all of this job. I think this is one of the challenges of this working party. Many thanks to many people, many seniors from US and from Europe, but also particularly thanks to Sankha, who also provided us opportunity in linking the young doctors, young family physicians at WONCA with the WONCA Working Party. This is the MHT project. Is a specific project that giving opportunity and strengthening family physicians who are in the front line, especially in settings affected by crisis, either ecological crisis, epidemiological crisis, or war and conflict. As a working party, we have prepared a couple of e-learning and website oriented material in supporting and strengthening the resilience of frontline physicians. There are a lot of methodologies used, and many thanks to Marilena Anastasaki, who actually on behalf of our steering committee working on that subject. We have, of course, another innovative, we can say, project, the music and health project already is at the end, has already published one important document. And many thanks to many leaders, but our friend from Brazil, Alfredo De Neto, I think that is a leader and the coordinator of this project. You can see now one of the first published activities within this project. But of course, we have in many other activities and also important approaches, models, steps, and how to promote integration of mental health into primary care. And now it's my pleasure also just a little bit giving a light to important opportunities and activities of Professor Abdullah Al-Khatami, who is also among us, is the vice chair of this working party, and certainly you have the opportunity in listening later on. Abdullah, many thanks in linking our working party with specific countries in North Africa and not only. And of course, we're having many webinars, conferences in many regions across the world, and of course, a number of these activities you're using. And certainly, one important task is the books. Now it's a pleasure for me in introducing the two books. The first book already just a couple of years ago, led by Professor Christos Dowrick, and now we're having the new primary mental health care models for interdisciplinary collaboration, a book that will be presented in the next WONCA World Conference in Lisbon. We're having many other opportunities. We needed giving a more focus on mental health and comorbidities, and that is the link between chronic illnesses and smoking as dependence, and that now is one of the promising issue. And certainly that I'm living at the moment, and just asking to continue with the next important speakers, just a little bit reminding the next conference, WONCA conference, global conference, and Lisbon, 17 to 21st September. Thank you very much.
Thank you very much, Christos, for that interesting information regarding the working party in a short time. I think it's very important to join the working party. Whoever interested in the mental health, they all are welcome to join the working party. Thank you, Christos, for that. And now, to continue your thoughts, I would like to invite Dr. Christopher Dowrick, who is the immediate past chair of the WONCA Working Party on Mental Health. And very importantly, this project, the MDD Minds, WONCA MDD Minds for Primary Care, is his brainchild. And I would like to introduce Dr. Christopher Dowrick. He's from United Kingdom, and he was the chair of the MDD Minds project, and was the immediate past chair of the Working Party on Mental Health. He's an emeritus professor. He's the emeritus professor in the University of Liverpool, general practitioner in Aintree Park Group Practice, and professorial research fellow in the University of Melbourne. And I think many of you know him, and I don't think much introduction is needed. Over to you, Chris, to tell more about this project, WONCA MDD Minds for Primary Care. Over to you.
Thank you very much. I've got a few slides. I don't know whether you should put my slides on or whether you have them on.
I think yes. I have given you the co-host, so you can share your slides.
Okay, thank you. Let's see if I can get this right. Okay, does that look okay? Okay, so it's my pleasure to give a general introduction to the MDD Minds project for primary care, and then more importantly, colleagues from different parts of the world will tell you much more detail of how things was working. This has been a really exciting project. I think it may be one of the biggest projects that WONCA has undertaken, and it's been literally a joy to be involved with it, with so many good colleagues, and with, as you'll see, a lot of success. So first of all, it's big. As Sankha has said, it's got an international reach. we deliberately were looking across the globe. You can see there, sort of in Mexico, in Peru, in Brazil, and then in Nigeria and Kenya and Saudi Arabia, and then in Indonesia and Sri Lanka and Japan. So right across the world, nine countries where we're doing this work, and then sort of a dozen countries involved in the creation and the management of it. The curriculum was designed to improve people's knowledge and skills, but also people's attitude and confidence in understanding and managing major depression in primary care. As you can see on the left-hand side here, we covered a whole range of options, from screening to diagnosis to different forms of treatment to different forms, to referral, and then importantly, looking at patient-centered care and self-care. And then going along with the several components, there was I'll say a little bit more about each. There's the MDD Minds 101, which is the online work, and then a train the trainer program, which was then spread by scholars in their localities, and then performance in practice. So a little bit more about those. So the MDD Minds 101, this was the one with the largest reach. It was available to everybody. It was a self-paced online course introducing key concepts in mental health. By self-paced, I mean it was something that people could do in their own time. We had it available in 4 languages. Obviously, in the future, can be translated into many more. So it's English, Spanish, Portuguese, and Japanese. We were aiming to involve 750 participants from the 9 countries. And it was a very effective platform. The folks organizing that had skill sets way beyond my own in terms of making it advanced and user-friendly. And I think it worked very well in that way. And then the second bit, which was a train the trainer program. So that was a course designed to equip trainers with the skills to teach and implement MDD Minds curriculum in various settings. And we were aiming to train 150 people to enhance their understanding and to increase dissemination. And that involved online content and real-time sessions. So people had to get together to agree to meet at particular times. There were 4 sessions which were facilitated by members of our master faculty. 3 of those sessions we had pre-designed the curriculum, but the 4th session was one that the people taking part in the program decided themselves of what they wanted to learn more about. And then each of the trainers who did training was asked to do at least one local training activity with local family doctors, primary care teams, or whoever they thought appropriate about some aspect of the MDD Minds program. And then separately from that, we had what we called a performance in practice program. This was applying theoretical knowledge in the practical setting, and it was implemented across 6 practices, 2 in each region, to evaluate real-world applications and outcomes. And we chose, for various reasons, I can discuss why if you want, we chose to focus on depression screening for patients with diabetes. That's because we recognized diabetes was something that most primary care teams would already be familiar with and might well have a register or be able to contact patients with diabetes. And also because depression is a common problem amongst people with diabetes and not always recognized or managed. It was a 12-week project, a swim lane analysis. That means we looked at which members of the primary care team had particular expertise, from reception staff through to the frontline physicians. It was a planning, and then a doing, and then a studying, and there was we looked at improvement over two separate cycles during the 12 weeks. It was quite an intense piece of work, actually. And these are the very broad headlines of what we achieved, and I think it's astonishingly good. So you can see that the countries which I mentioned already, almost 3,000 family physicians from 26 different countries, not just those 9, enrolled, of whom 581 completed the course, and that's very good considering the rate of attrition you often get with online courses. There's a very good proportion. We had the master faculty from different countries, and then 210 scholars enrolled in the trainer program, of whom more than half, 126, completed it. And those 126 people delivered 143 sessions, so more than one each, to almost 1,700 learners. That to me is an astonishing result. And then in the performance in practice, we had 7 practices, not 6, got involved in screening patients, and they screened over 1,000 patients with diabetes. So it's a huge amount of work went on, and I was really impressed by how our colleagues across the world got seriously engaged with this. And so my final slide, these are my broad conclusions. First of all, we've shown that members of the WONCA family can deliver high quality education at scale. We can do this at an international level. We've shown that as a result, and you'll see more details in the next few presentations, family doctors did increase their knowledge, their skill, and their confidence in addressing depression. This did have a positive impact on patients' mental health and well-being, and that's obviously the most important thing of all if we're actually helping patients' quality of life to improve. And broadly, I think what we've shown is that this approach, this MDD Minds approach, is replicable and sustainable. We're very keen to expand this program in many other parts of the world, but also the approach could be used with other problems, with other clinical situations. It doesn't have to be specific to mental health. So that's all I want to say. Just a very, very upbeat, very cheerful, very pleased about how well this has gone, and my thanks to the literally hundreds of people who are actually involved in making it happen. So thank you. I'm going to stop sharing now, and I'll hand back to Sankha.
Thank you very much, Chris. I think you should be very happy about the outcome of the project, and of course we have a way to go. And I think not only you, also the Christos as the working party chair should be really happy about the project, and how we received what sort of a response we received from the piloted countries and the family officials there. So thank you, both of you, as our mentors. Now we are moving to the faculty, the master faculty members. As I told, we had several master faculty members from the 9 countries. And it's very important to listen to their thoughts, what they share, what the experience they had from this throughout the last 2 years from this project. So the first master faculty member I'm going to introduce is already on the screen. That's Dr. Abdullah Al-Khatami from, he's a consultant family and community medicine physician from Saudi Arabia. And he's a very well-known family doctor there who has engaged in a lot of projects. And also he's the vice chair of the Working Party on Mental Health. And he's also, even though he's a master faculty member, he's also one of our mentors. Over to you, Abdullah.
Thank you, Sandra. Thank you, Anna. Thank you, everybody. I'm very happy to meet my family here. Really, it is good journal and fruitful. Go smoothly, and to share what's going on in Saudi Arabia. Saudi Arabia, one of the countries, try to integrate mental health in primary health care since 1995. We start by situation analysis, then test the hypothesis, start primary mental health program 2003, 16 generalized program. But that time we use the psychiatric or what is called traditional doctor-patient interview approach, which is make it a barrier really for family doctors to introduce a good mental health, because this is not our a job that patient will come pure and just clear that he has mental health. No, our patient presented with physical symptom, with medical problem. So this is why it is mostly of these cases maybe reach more than 95 of case missed in primary healthcare. So that's which is encouraged us to create the new approach called 5 steps in 2017, and was assessed in Egypt also and generalized in Egypt in 19, then apply in different countries as mentioned by Professor Christos. When MDD program really that was like a fruitful application for the 5 steps, where we can encourage our people to apply the MDD program through and using that new approach, 5 steps approach, which taking only 5 minutes to interview the patient and diagnose and discover is the patient presented with mental health or not. And we are working in Saudi Arabia, and countries were trained, and I hope our group in coming months or years will be put as a proposal, chronic medical disease control through psychological stress pickup and management. And this is the approach which can be used. In 5 minutes, we can pick up if the patient has mental health or not. And these steps, without going at details, it's consisted of 5 steps. The first step is who patient is suspected to get or to have the mental health care. Our problem is in this no pathognomic for mental health disease. Diabetes will be presented with drinking a lot, urinated, patient with bronchial asthma, presented with cough and short breath, and this will help the patient and guide patient to follow the guideline. But how the depression will be presented in primary health care, how anxiety will be presented in primary health care, no pathognomic for that. So we put by this approach, and by any way, it is very valid and very reliable, and compared with expert psychiatrists and WHO screening tools, BHQ9 and GAD7, and published in WPMH GAP in 2022. And suspected, we look for 3 types of patient: those who is uncontrolled chronic disease or physical complaint, frequent visit, and sleep problem, sleep difficult. These patients then will move. If the patient hasn't this one, we provide the normal or traditional care. If we have this patient has one of the suspected group, we move to screen. In screen, we have 2 part. First part is this patient has delusion or has hidden agenda? We use eyes technique is known. And if the patient has psychological stress or not, we ask 3 questions. One about the sleep, early insomnia, interrupted sleep, and concentration and performance, is it decline or not? Relationship, he has easy anger, has liking to be isolated or like to be alone. This is, if he one of these, yes, we'll move to the scoping. Is the patient need to be carry care in primary health care or move to psychiatrist? If it is just if he has no psychotic illness symptom, postpartum drug, we refer him to psychiatric. If the patient only has depression or anxiety or one type of anxiety, we continue with the patient and diagnose is he has depression or anxiety or both by using PHQ-2 and GAD-2. Then management, it is also scheduled and straightforward for primary health care. If the patient has only insomnia by stress degree, he will not use medication, just by non-pharmacological. And even non-pharmacological is 5 things, and needed vitamins and minerals, that's nutrition. But if he has moderate to severe, which is mean that he has interrupted sleep, affecting performance and concentration, affect the relationship, plus the non-pharmacological, we start by simple dose of antidepressant. And usually the prognosis of our patient, 1 to 2 weeks improvement, 6 to 8 weeks, we get remission of the symptom. If not, like if he has phobia or panic, usually takes some time. The patient's body will tell us how can we deal. He has more anger, he has more sleepy. According to that, from the experience, we can interpret his problem, how we can support him. This is really what is us in primary health care. So thank you for those who run and work and create a very wonderful program. MDD was very helpful for us, and we to implement and make confidence by using the new innovative approach. What is my recommendation or recommended from our experience in Saudi Arabia is to build our ability to meet our patient with a suitable patient interview, goes with family and primary health care setting, not specialist. This is why the family doctor and primary care doctors, they not encouraged to apply mental health because they think they should use the psychiatric approach, which is need time, and they don't have that time. I hope to collaborate more in this side, and I am very happy to join any country want to apply this approach, either face-to-face or online. It will be my pleasure. Supporting really my group in WONCA by guidance of Christos. He's very, very supportive, really. Share with us in Egypt, in Tunis, in Morocco. Anywhere I will find my support from my colleagues, is particularly Christos. Thank you all, and I hope the best.
Thank you very much, Dr. Abdullah, for that insightful sharing of your work in Saudi Arabia, most of the pioneer work. Thank you very much. So with that, now we are moving to another master faculty member. So we are moving to Peru now. We have Yasmin with us, Dr. Yasmin Cordova from Peru. Is a family doctor from Lima, Peru, and she holds a master's degree in community mental health, and this was followed in Barcelona University. Now, Yasmin works in a medical center with patients with substance use disorders in Barcelona, Spain. Yasmin, over to you to share your thoughts and experience in Peru with regard to the MDD Minds project.
Hello, good. You can listen to me? Good afternoon.
Yes, we can hear you.
Okay, so I will try to share the The okay. Okay. Okay, you see. Okay. Yeah. You can see my slides, Sankha? Okay.
Yes, you can expand and put it in the presentation mode.
It's okay now?
It's not in the presentation mode, but we can see the screen.
Here, it's okay? It's okay like this?
Yeah, but you can put it into the presentation mode. From down,
okay.
yeah. Yeah.
It's
Go
okay?
ahead. Yes. No,
Yeah.
no. It
No?
didn't. Click it.
Yes.
Like this is fine? Now? It's okay?
It's fine. Yeah, you go ahead. Yeah.
Okay.
No worry.
Good afternoon with everybody. I'm happy to share today with you, and I will explain a little how was the process of with the Peruvian family medicine doctors. So first we start with this course, and we did it in English, and after that we helped to do the traductions in different. So we did in Spanish. So for people from South America, they did the course in Spanish. So now is you can see it in English, Spanish, Portuguese, and Japanese. So when when the family doctors finished the first step of the course, the next step was the train the trainers program. So we had 4 online meetings. That this is a pic of our first meeting. So was little difficult to find a day and an hour, but at the end we could do that. So we were happy to have our first meeting that day. And we also continue with 3 more meetings, were 4 online meetings. The first one was about screening, diagnosis, and treatment of depression. The second one, the non-drugs interventions. The third one, mental health and substance use disorders. And the fourth one, the follow-up, referral, and self-care. We had a platform of Trello that helped us to do these meetings. We were talking about different topics. We were talking about the importance to take care of our health first, to help other people, to take care of our patients. We were talking also about the importance of our relationships with our families, our friends. And there are also some difficulties in the infrastructure of the medical centers, and the difficulties of to do a reference to psychiatry if it's necessary, and also other factors that can affect our mental health, like violence, insecurity, stigma, social injustice, and the responsibility of the government. So there are a lot of things that affects our mental health. So, but at least we can try to do our part, but it's multifactorial. So we had interesting discussions about these topics with Peruvian family doctors. After this, we had community activities. Some of them were presential. Here is Dr. Angel, who had a reunion with the people of his community mental health center. And here is another doctor, Dr. Julia, who had also a meeting with 2 I think were maybe a psychology and a nurse. So they were sharing also talking about depression in primary health. And they also did some online meetings, like talking about depression, Dr. Jorge and Dr. Erica. and also the group of Huaynacae, Peru, that are the young family doctors, also organized another reunion about talking depression. So they did a great job, and I give congratulations to them. So they were enthusiastic. And we also have two testimonials of two of the participants. Veronica said that it was an opportunity to strengthen her knowledge and connect with other colleagues, and was important to learn about their experiences. And Eileen was talking that was opportunity to help her to reconnect with herself and share tools with others, an opportunity to grow personally and professionally. So this was our work in these last months with the Peruvian family doctors. And we also talked about the activities that can help our mental health, like doing some music, connect with nature, also to dance and to share with friends. And we had a meeting in Lima, Peru on January, where we were sharing chicha morada, like that is a Peruvian beverage. So with this, I finish my work for now. Thank you very much. Okay, I will finish. Okay.
Thank you very much, Yasmin. Gracias por tu gran trabajo. You not only worked in your country, but also you helped us in translating the MDD Minds module to Spanish. So we always remember that as well. So thank you very much.
Yeah, it's open for all people that need to read it in Spanish, so we can continue with other people that haven't done this now. They can do it.
Thank you. So now from Peru, we are going to Mexico, and we have Ana Perez with us. Ana not only was one of the master faculty members, but also she was instrumental in organizing this webinar. So thank you for that, Ana. And Ana Perez is from Mexico and a family medicine specialist and a high specialist in medical family therapy. And also, she's the Young Doctors Liaison in Working Party on Mental Health. And one of our colleagues, master faculty members. Anna, over to you to talk about addressing depression in primary mental health care in Mexico while you were engaged in MDD Minds project. Over to you.
Thank you, Sankha, for this kind presentation. Yes, and well, in Mexico, there is an estimated of 3.6 million adults suffer from depression, with a significant percentage of cases being severe. That's really important to address that. It's so important to have family medical doctors to be prepared to diagnose this pathology, but also to implement pharmacological and non-pharmacological treatments. In Mexico, we have some challenges like cultural, because many of our population have or consider different kind of aspects around depression. We have two languages barriers, like we have indigenous languages. We also have segments of the population that we know deal with mental health issues differently according of this cultural difference. The lack of specialists in family medicine that allow timely diagnosis, as I mentioned. And in Mexico, there is a shortage of psychiatrists. But we need to, we cannot be able to prescribe a lot of treatments without an evaluation of the psychiatrist. About MDD Minds, we had 18 doctors complete the online course. 7 doctors initially complete the first phase. Only 2 doctors continue in the next activities, but in general, among the practice, they would be willing to implement were non-pharmacological techniques. In the train the trainer phase, we had 2 doctors that completed train the trainer, and it was conducted in Spanish via Zoom. A total of 8 sessions were carried out in this phase between September and October from 2024. And I think that the most important result of this project is that the colleagues want to continue treating and teaching about these treatments and this manage of depression. About the sessions that they had, Dr. Dulce Adelaida Rivera Avila, one of the trainers, had 2 sessions. As you can see, she obtained very wonderful response about the number of the participants. The Dr. Marian Flores Morales had 2 sessions with 29 health workers, and they were so motivated too. About the lessons learned and challenges, well, primary care professionals need to be trained in mental health, not only for diagnosis and treatment, but also for support patients and their families. It is important to validate what is already being done and recognize this. And it is important too to make a healthcare worker burnout visible, the difficulty of finding a suitable time for participants, and the importance of self-care and the multidisciplinary teamwork point of view. Another challenge during the project in the train-the-trainer practice, I'm sorry for this part, but is the difficult access to educating someone else and administrative barriers to prescribe at primary care in some contexts. Well, thank you to be here, because we know that in middle of the week it's so difficult, but thank you. That's all.
Thank you very much, Anna. Thank you for explaining how it went well in Mexico. But I also remember that you took over the faculty member position when we were in a difficulty. So you did well, and you showed us it's not only a quantity, but also quality is important. So you did well, you nailed it. Thank you very much. From Mexico, thank you. From Mexico, we are moving to Indonesia. We have one of our master faculty members with us, a young colleague, Dewanto Andoko from Indonesia. He's a resident of the Family Medicine Specialist Program in Indonesia, and also a research assistant of the Psychiatry Department. And he'll be sharing his experience on behalf of Indonesia about the MDD Minds project. Dewanto, over to you, and you can share your presentation.
Thank you, Sankha, for the introduction. So I'll be presenting about the depression management training in primary care as the outcomes from the MDD Minds Indonesia program. So just give you a little bit of a situation of the mental health, and especially depression in Indonesia. It's a high burden and low access problem. Yeah. Over 10 million Indonesians experience depression annually, with a treatment gap of over 90% do not receive adequate care because of the stigma and lack of awareness as a major barrier. Also, primary care in Indonesia as the front line for managing MDDs is under-equipped as primary care doctors, even though as a first contact for MDD patients, but they often lack training in mental health for screening and also diagnosing, also managing the depression. And there are also limited time, resources, and also unclear referral pathways. So there are systemic challenges. It's because like everywhere in the world, maybe there are shortage of psychologists and psychiatrists, especially in the rural areas, and also inconsistent integration of mental health into primary care service. The weak mental health surveillance and data systems that are still prevalent in the country. So the good thing is that there are new initiatives in helping these. So the Ministry of Health have already pushed the integration of mental health into the public health centers or puskesmas in Indonesia via promotive and preventive program, equipping around 200 or so mental health puskesmas. So they also equip it with antidepressants, antipsychotics, and also the training for the community health workers in mental health. And capacity building training, such as train the trainers in MDD Minds, is also gaining momentum. The universal health coverage in Indonesia, so we already have a universal health coverage, has also included a basic mental health service, although we still have an urgently need of strengthening in training, reducing of stigma, and also improving referral and support system in primary care. So the overview of our training program, the MDD Minds in Indonesia, the objective was to enhance the training for primary care physicians on MDD management. And the interesting thing about the training in MDD Minds in Indonesia is also train the kader kesehatan jiwa or mental health community health workers, such as nurses and midwives who are in charge of the program in their public health centers in their areas. So we also included the training of our scholars train the community health workers. So the key phases is as told by Prof. Christos and also Chris Dowrick. There's an online course 1, and then the train the trainers, and also within the train the trainer, there's also the performance in practice. So in Indonesia, there were 374 registered participants of the online course, with 95 finishing the online course. So the attrition for an online course, but there fortunately there were still 95 participants who finished. And then from the train the trainer phase, there were 30 participants from all over Indonesia, and with the master faculty, including myself and 1 moderators. All the sessions were conducted entirely in Bahasa Indonesia. The attendance ranged from 21 to 30 per session, and also with a high engagement rate despite weekend scheduling conflicts. So there were also recording available for its sessions. And before the sessions, we did a pre and post test, and that shows a marked improvement in the knowledge, screening, diagnosis, management of MDD in primary care, and also the self-care for clinicians or community health workers. The scholars is also successfully adapted the training to their local context in each of their areas. So this is a picture of one of our scholars doing community health sessions to train the community health workers in their public health center. So 18 out of the 26 scholars implemented the MDD Minds training or the train the trainer in their own communities. And they also did a customization of the modules based on the local needs with the active participation in case discussion and small group. And the good thing is that there's a WhatsApp group support that can facilitate ongoing mentorship for each of the scholars. This is the scholar community sessions. It's not attended by only physicians, but also nurses and midwives, working in primary care clinic and also community health centers. This is another photo from our scholar did community sessions. And this is a few of the translator training material and tools that is translated into Bahasa Indonesia and is used in the training. So here's a few testimonies from the participants from across Indonesia. A lot of our scholars did testimony and shows that the testimonies were overall positive. The challenges and lessons learned from this training program is that maybe the weekend schedule and context is some participants have other trainings or other things to be done in the weekend. So maybe that's why the number fluctuates. And also obtaining the CME accreditation for the training. The next step and future plans for the MDD Minds training in Indonesia is to expand the training programs to more local trainers, continued refinement of the training materials in Bahasa Indonesia, and also research on the effectiveness of the module itself, with collaborating with the alumni for further train the trainer cohorts in the future. Thank you. That's all from me.
Thank you very much, Devanto, for that presentation, and thank you for your great work in Indonesia. And especially we are very happy as a training in family medicine, what you did, and you showed that what a young doctor could do and what change a young doctor could do in this field. So thank you very much. And now we would like to move to the next item. Before taking your questions, I would like to invite Professor Christos Lionis, our chair of the Working Party on Mental Health, to discuss about the way forward in this project. And also you can invite our participants and the people who would watch this program later to join our program in future. Over to you.
Thank you very much. I very much appreciate. And since we need it in giving opportunity also for raising questions, and we're very impressed from the contribution of all MDD protagonists. I'm not planning in giving any specific academic lecture, just only colored concept and potentially giving more focus on the concept. This is a presentation already we have discussed with our steering committee and reflected many of ideas and concepts have been raised and initially discussed. And I supposing that the next step of MDD is just to expand in giving more focus, certainly in methodology and means are very well tailored with the needs of the younger people. That is very much important. And that to that reason we needed to having a clear feedback, as already many of the presentation in testimonials provided the feedback from the younger colleagues and physicians, and always strengthening and raising the issue for the local adaptation. That is very important. I think that we needed more work, more strategic plans in seeing to what extent MDD project, the material we have at our hands, could just support the direction already initially have discussed in our working party, just linking the principles of a standard declaration together with the concept of MDD. We think that still, despite the epidemiological crisis at the moment overpassed, we having people affected by many crises across the world. There are many places where conflicts and wars at the moment, and also we have many settings affected by ecological crisis and natural disasters. That the concept of vulnerability is very, very important, and to our view, it is very important in thinking more focus, more expansion of the MDD project in covering the need of vulnerable people. This is a quite UK initiative, but we think that it was one of the most successful, trying a little bit in linking a healthcare domain with the community settings and giving the opportunity and using appropriate use of non-medical sources, especially for the vulnerable people and also for the seniors that have been affected by social isolation and loneliness. I think that we need a little bit to thinking more the community orientation of the MDD, as already has been done, but potentially just such expansion utilizing effective models like in the social prescribing, I think is very important. We have already discussed, and that is quite a key issues in exploring further. Of course, there is a reference to MDD projects, but potentially we needed a little bit in thinking more to the provision of compassionate care, giving more focus on so-called the concept of self-compassion. I think that is one of the key issues. And you can see a couple of materials we have, and the latest is compassion and primary health care from WHO. I think that there are many other excited ideas. This is narrative medicine as a tool, as a method, as an approach, initially rooted from Columbia University in New York. To our view, we needed a little bit discussing and potentially seeing how additional sources when we're exploring integrated care and especially when we teaching the young physicians to what extent additional input from even from non-medical sources, that is quite important. This is another issue, very sensitive as a working party. We had the pleasure with my colleague and friend Chris in having exploring a further discussion of the concept, the notion of suffering. Has been also opportunity in a bit giving a more focus on MDD project on the suffering, and especially suffering not only for those that have been affected by a severe illness, but also especially for young people, they suffering or understanding the change that the world is changing, and also especially for those having a better understanding or affected by all pervasive suffering. I think that's all of this type of suffering needed. But also another important issue, so already have discussed an approach, but we thinking in teaching more our next generation of family physicians how to assist their patients to identify that the life is meaningful, it's manageable. That's having a better understanding of the meaning of their life. I think that is one of the challenging issue we have, since already there is supporting evidence that meaning is mediated between suffering and well-being, and well-being is a key issue at the moment. But that is the final. Of course, we are addressing and giving many responsibilities to family physicians, but having an understanding that family physicians are also human beings that having the opportunity not only to make mistakes or falling in failure, but also just affected by compassion, dissatisfaction, and also that's having also burnout as a real risk. That is very important also, this MDD project, and finally giving more focus on so-called mental health resilience, and making our people, our physicians, the new generation more resistant to international pressure and crisis. Thank you very much again. Very much grateful to all of you who coordinated this important webinar.
Thank you very much, Christos, for those thoughts. We will move to the questions now. Before that, I have to thank one of our colleagues, that is Fabiola Ugarte, a young family physician from Bolivia, who joined us with Spanish translations. Thank you, Fabi. Thank you very much. We had one question about integrated behavioral health. The question is, does any one of you know the concept integrated behavioral health? Of course we know, because we practice this in one of the WONCA projects, that is the Advocacy project. And it has also, the question also tells that it is started to be used in Sweden with success. I think Chris can answer this question. What is integrated behavioral health, and how successful this is, and how we did it? We used it in one of our projects.
Certainly, yeah. Well, I mean, integrated behavioral health it's just a different phrasing. It's really the same thing as integrated mental health. Behavioral health is a term that's used more commonly in the United States of America. Mental health is used more commonly in Europe. But it's the same thing. It's about helping people, helping professionals, helping primary care professionals become more confident in understanding and diagnosing and managing psychological, emotional, behavioral, mental health problems. It's broadly the same thing. Sorry, what was the second part of the question, Sankha?
About our advocacy project.
The advocacy project, yes, absolutely, yes. I mean, that's a project that Christos mentioned in his initial presentation. Sankha and Yasmin and a number of people on this call were very much involved with that. That was a project which has had two phases. The first was during the COVID pandemic of the year 2000, and the second was last year, where we engaged with a total of 20 young family doctors from different parts of the world, mostly from low and middle income countries. And we were working with those family doctors to, again, to increase their knowledge and skill, but mostly to increase their confidence in being able to initiate change in their local environment, whether it's, in some cases it was in their practice, in some cases it was in their community. One or two young doctors, that they were actually in a position to influence policy at a national level. So, but it was all about sort of finding the confidence, the skills, the techniques, the political awareness, if you like, to work out how to make the things that we believe are important about integrating mental health, integrating behavioral health into primary care, how we can persuade other people that those are important, and how we can get change to happen. There was a publication about that in the British Journal of General Practice a couple of years ago. There's a report that Christos's colleague Marilena has produced on the most recent project, and that will be published in due course. You'll find some materials on the WONCA website on that as well. But certainly, if you're interested, if people want to get in touch with myself or Sankha or Yasmin or Christos or Duanto directly, we can provide more specific information about that. Again, that's another project that I think small scale so far, but it has a real potential to be scaled up. I think the techniques that we have developed there are very effective and very reproducible.
Sankha, many thanks to Chris. I'm just a little bit presenting this book. This book is already focusing on integrated primary and behavioral care, spring care. Is exactly that Chris said. It is an integrated model. This term most cultivated in US. This book that already put in the chat is a couple of years ago by Springer. We're giving a more focus on a definition of behavioral care, but exactly that's as Chris already explained. But this book potentially giving, and also Chris potentially together with you, with all the young colleagues, with Dr. Abdullah, potentially we just a little bit focusing on our next book of working party, focusing on this integrated primary behavior care, incorporated. Yes. All of these models already have been presented. Thank you.
Thank you, Christos. We have another interesting question from Dr. Puntuno from Myanmar, who's a primary care physician from CLA Health. He has asked, do you have contact with any doctor in Myanmar? You all may aware that the Myanmar has a lot of war refugees, that is IDPs, who definitely have more or less depression, anxiety, and insecurity. So I hope one of our doctors can join the train the trainer program. What do you think about this, Chris? I think it's a very
very important. I don't know the detail, but I know there have been big problems in Myanmar in recent years, and very concerned for the mental and physical health and safety of thousands and thousands of refugees there. I mean, the specific answer is that the online version of MDD Minds 101 is available. It's available online for anybody who wants to use it, but it's in the languages of English, Spanish, Portuguese, and Japanese. So if that is of any use to colleagues in Myanmar, please look at it today and build on it. Further than that, if there's an interest in particular, in translating into local languages, if there's an interest in train the trainer initiatives arising from that, we would be very happy to talk with Dr. Ton U or whoever else it might be in Myanmar and see what's possible. I mean this is exactly the sort of question that we want. We are very committed to building on this in ways that will help people in many different countries.
Not only that, I think we had a module on self-care as well. So in a country like that, I'm sure that the family physicians need to keep their mental well-being also in a good.
Absolutely right.
Yeah. So I think, of course, you are welcome to follow the MDD Mind open course. I have already put in the chat the websites. I think I'm correct. It's www.mddminds.org, right? I think I'm correct. So you can access all the modules free of charge, open in this open source website, and get yourself trained. But also you are welcome to contact our working party for further support. So we are always welcome for that. I would like to take this question because from Hamid. He has told there's a risk with disease mongering, especially since Pfizer is the sponsor. I can, of course, answer this question, but I would like to get an answer from Chris.
Hamid, thank you very much for raising that. That was a big concern that I had at the beginning of this project. And clearly, like you, well, I'm assuming you, there are concerns about pharmaceutical involvement and about a sort of an underlying assumption that this will all lead to more prescribing of antidepressant medication and more profits for pharma. And that was my concern. I have to put my hand on my heart and say I'm not so concerned about that now. Pfizer did provide funding for this, but there was no restrictions whatsoever and no input from them at any point whatsoever in the whole project about the content or about the direction that we were looking at. And if you look at, if you go into detail and you look at the content of the course, certainly that there is one important and valuable module on pharmacological prescribing, but that's preceded by a much more substantial module on non-drug treatments for depression and mental health problems. And I think if you look at the course as a whole, I hope that you would be assured that we are not looking to increase unnecessary diagnoses, which I think is an issue in some high-income countries like the United States or the United Kingdom, where there's perhaps a tendency to overdiagnose. There is a tendency to overdiagnose depression. I think in low and middle income countries, certainly the countries that we were looking at, the tendency is still to underdiagnose. So I understand and I accept your concerns, but I can put my hand on my heart and say that I do not share them in the context of the MDD Minds project.
Thank you, Chris. And we all, as the master faculty members, we can witness the same. We are witnesses for that, because I don't think that I don't think at all that Pfizer has anything to do with content, because after this unconditional grant, it is an unconditional grant, very importantly, there was no involvement at all for content creation or anything else after that. And WONCA specifically is very much concerned about its grants and the pharmaceutical connection. So WONCA never accepts any conditions when it comes to these sort of grants, especially from pharmaceutical companies. So thank you, Chris, for answering properly to that very important question. I think those concerns are very, very, I mean, could be very, very fair. And I would now take a question about, sorry.
Question there about social prescribing, which is the issue.
Yes, that's it. Yes, social prescribing. How do you estimate the level of understanding and support, and therefore the effective implementation by healthcare professionals, community authorities, and policymakers as well? Abdullah, would you like to answer that question about social prescribing? The question is, how do you estimate the level of understanding, support, and therefore the effective implementation by healthcare professionals, community authorities, and policymakers as well about social prescribing, estimating the level of understanding?
Yeah, I think the people, when they find the service available around of them and they are seeing the outcome of that intervention, how it is effective, how it has changed their life, I think this is the more help to be social accept the service. By anyway, we use just a simple drug of SSRI, for example, which is can be 1 or 2. It is not that cost, but it is save a lot of health resources. One patient came today and she said, Doctor, I feel just through 3 days, 3 weeks that I am different person. I'm joking with my family, my friends, my children, my husband. I'm even play with them before. Just my mind is running away, worry about them, why they run here and there. And not only that, she brought her mother, and she said, I have one sister is tense, and we need them to be relaxed. So the message here in conclusion, that the society, whatever you do without show them how it is easy to pick up, easy to manage, how quick respond, still the stigma will be a barrier. But if they saw this one and how they came, for example, to manage her hypertension or diabetes, and they found a trained doctor who will explore and pick up if he has stress or not, and he explained that we cannot manage depression, diabetes or hypertension or body ache without declining the steroid and norepinephrine in your which is the stress hormones. So I'm sure the society, whatever, where is it, they will cope the stigma. So we can start self to improve our skills and pick up quick deal to find a quick fruitful outcome, and this is the which people in our society accept our work.
Thank you, Abdullah. Christos, do you have anything?
Yes, I think that is a very old notion. Primary care oriented means oriented primary care to the community. This community orientation was a very old concept. Certainly, the social prescribing has a roots to UK, but there are many important paradigms and examples across Europe, even in Greece. But unfortunately, there's a so-called intersectoral collaboration, as WHO suggested this from the Alma Ata Declaration, still is in front of us. That potentially we needed, even as a working party, exploring best practices and effective paradigms across world and also just disseminated. I think that is a very important area, potentially one of the future steps of MDD, utilizing best examples across world and giving opportunities for non-medical intervention, or in otherwise that's a synergy and integration between primary care with the community sources and stakeholders. Thank you.
We put also a link for more information about social prescribing in the chat.
Thank you, Yasmin. And also I saw Chris has had put one of the evidence-based, I think, analysis, an article also in the chat, so you can refer to them. So thank you very much, Christos. So we spent almost 1.5 hours together. So thank you very much, all the past participants, for being with us. And thank you, our mentors, Christos and Abdullah, and all young doctors. I realized almost everyone is a young doctor who was leading this project in those countries. So thank you very much for the speakers as well, and thank you, Fabi, for Spanish translation. And I invite you all to join the MDD Minds project, and also join WONCA Working Party on mental health, and in celebrations of Family Doctor Day. And thank you for joining today. So thanks everyone. Have a great day.
Sankha, This will be
Yes.
recorded, isn't it? And will be in YouTube, the channel
Yes,
of WONCA.
yes. As you are already put in the chat, this has already been recorded, and this would be on the YouTube soon.
We can do a group
we-
photo,
Yeah, a
Yes,
picture.
always, yes.
Yes.
a put a pic together, maybe. Thank you very much for all your time and all the effort to do this. And a special thanks to Anna, who was coordinating with us. Thank you very much. Congratulations for all your effort.
My pleasure.
Thank you.
Yes,
Oh,
thank
okay.
you. Thank you all.
Thank you all.
Thank you very
Thank you,
much.
Saha. Thank you, Anna, for good organization, really, and remind us frequent to attend this very fruitful meeting. Thank you all.
Excellent. Thank you very much. Thank you.
Thank you very much, and have a nice day.